this year, the nursing session will evolve around role of nursing empowerment, which is today, role of nursing empowerment to foster a healthy workplace environment and bridging the gap, developing, growing, and conquering in nursing. So to enhance the experience of nurses and other participants, keynote address from reputable professors, national and international nursing speakers are invited. These experts will share their research work, their knowledge, and also they will help us to develop capacity of networking for all the nurses around the world. In a nutshell, the symposium is a great opportunity for nurses working in clinical practice, education, research, to interchange and disseminate ideas and explore further opportunities for nursing advancement across the globe. So we are grateful for all of you, your presence here, and we believe that we will be able to make this event an exciting opportunity for all of you and other healthcare providers as well. I would request the guests to please put your phone on silent so that you can have a smooth and calm presentations and you can enjoy them. Registration is free, you all know. Those who have not done registration, they can do sitting in the hall. And the more important thing is to please put your evaluation forms online because your registration and evaluation forms are compulsory to get you an electronic certificate, which will be sent to you on your email address. And there's another announcement I want to make is that there is a session tomorrow where we will be looking forward to have you with us. Thank you very much. Thank you, Mr. Nana. So for our first guest, Stella Nolan. Stella Nolan is a PhD nurse and working as a chief nursing officer for Queensland, Australia. He is also an adjunct professor and has many reputable publications to her name. He's going to talk about fostering nursing leadership at all levels, foundational principles. This is a virtual talk. Hi, I'm Shelley. Today I'm going to suggest fostering leadership at all levels, foundational principles. I would like to begin by acknowledging the traditional owners of the land that I am presenting to you from their connections to land, sea and community. They are the Jagera and Terrible people of Meanjin, which is the traditional name for Brisbane in Queensland, Australia. I pay respect to their elders, past and present, and extend that respect to any First Nations people from Australia who happen to be joining you today. I also acknowledge the Indigenous people of the places where you live and work, recognising the language, culture and beliefs that contribute to the delivery of health services all over our world. Fostering nursing leadership at all levels is exactly that. This presentation will explore how to have a collaborative, supportive conversation between employer and employee that enables employees to remain productive whilst meeting their caregiving obligations and professionally leading at all levels of the healthcare system. Across the globe, we have to seize the current opportunity to transform workplace culture around caregiving and promote gender equality in the workplace to promote the nurse's voice through leadership to support nurse-led care and multidisciplinary teams. We know that there is more than enough for all of us, and we need to ensure that we can lead healthcare together. Across the globe was a time to celebrate the Year of the Nurse and Midwife. During that time, our office had just launched our strategic plan with a vision and a mission that could focus on the drive and the key priorities and strategies led by nursing to support the department.
So what a different year the world had, and in many countries, the foundation of care was provided by nurses during the pandemic. In many ways, these were on the ground of leadership, system leadership, and care directions made the world of difference for all peoples and all communities. To have good leadership, you need to start with the value proposition. Nurse leaders need to be supported, focused on health and wellbeing, and productive workplaces are paramount. The importance and value of workforce culture as a leader supports initiatives in the workplace to promote a positive culture. Positive practice environment is what makes this a great place to work. People want to come to work, and organisations need to attract nurses to work for them. And this is based around magnet principles, not forgetting the importance of recognition and value. The Queensland Health Leadership Strategy for Nurses and Midwives was born from the Early Career Nursing and Midwifery Retention Strategy, and it was our focus area 3, which recognises the importance of investing in leadership support, development and training. The leadership strategy was developed through consultation and representative nurses and midwives, including First Nations colleagues from Queensland Health, Hospital and Health Services. The Executive Directors of Nursing and Midwifery and the Government Election Commitment combined working group provided guidance and direction for this strategy. Support and encouragement were offered by the Nurse and Midwives Implementation Group. As an inaugural resource, the leadership strategy provides guidance for a continued and coordinated approach to developing, supporting and enhancing leadership capability and capacity for all classifications within the nursing and midwifery professions. By empowering leadership at all levels, we foster a culture and profession of high-performing, innovative and future-focused nurses capable of providing and making a positive difference to all Queenslanders in the care that they deliver. The COVID-19 pandemic caused profound disruption to the healthcare system and wide-reaching health, social and economic impacts globally. In response, nurses and midwives rose to this challenge, adapting and collaborating with interdisciplinary colleagues. They leveraged new ways of working, implemented innovative models of care, strengthened effective partnerships, and embraced new systems and technological advances. However, many challenges are ahead of us, with changes in technology, consumer preferences, workforce shortages, and increasing population growth and incidence of chronic disease. There has never been more important time to invest in nursing leadership. The leadership capability and capacity of nurses and midwives is just as important to providing quality patient-centred, women-centred care as our technical abilities. Nurses and midwives must lead in improving work culture and processes, creating new integrated practice models for cancer care, and working with others to contribute to crafting policy and legislation that encourages every nurse to be engaged with the profession and enthused to provide care to their optimum scope of practice. The strategy here in Queensland forms an essential component in obtaining the best engagement and outputs from all members of the professions of nursing and midwifery, as it promotes professional culture and safe work environments, high quality care to improve individual and population outcomes. And this is really important in a multidisciplinary team approach in providing cancer care. Explicit within the strategy is the objective to foster First Nations leadership for both nursing and midwifery by encompassing requisite initiatives to contribute to building strong First Nations leaders, increasing representation across all classifications and improve First Nations consumers' access to sustainable, culturally safe and responsive healthcare services. Additionally, the strategy identifies the needs for increasing the proportion of nurses, midwives and First Nations colleagues in transitional leadership roles. The strategy essentially aims to deliver an overarching resource that provides all classifications of the nursing and midwifery professions with clear direction on how to build leadership and advocacy, capacity and capability, and apply these tenets to achieve clinical, organisational, professional and personal goals. Also, to promote First Nations nursing and midwifery leadership by including requisite initiatives to contribute to building strong First Nations leaders, increase representation across all classifications, and improve First Nations consumers' access to sustainable, culturally safe and responsive healthcare cancer services. We also want to clarify differentiation between the professions of nursing and midwifery by incorporating specific priorities and initiatives to commence to address underrepresentation and increase leadership capacity and capability in midwifery. We want to enhance linkages and improve those linkages between the organisation, care provider and the systems of care, identified through an integration and interrogation of literature and Queensland Health Nursing and Midwifery frameworks and state, national and international strategies. There are three key focus areas of leadership for the professions: leadership capacity and capability, leadership pipeline and career pathway, leadership culture and systems. Each focused area has two subcategories, and against each of these are wide-ranging initiatives, with many of these predicted or predicated on specific activities of other nursing frameworks, strategies and plans. The strategy has key initiatives that apply to all classifications of nurses in Queensland. It means that we have a framework for developing, attaining, maintaining and enhancing effective leadership skills. This interconnected approach was deliberate to highlight the array of resources that need to be considered when creating innovative and inclusive opportunities for individuals to reach their potential. The strategy focuses on initiatives that will be implemented from a statewide perspective, health service level, professional and individual context over the time frame of the strategy, in line with corresponding annual action plans. It is also envisaged that those hospitals that are magnet hospitals will use this as a basis. In Queensland, the importance of leadership for nursing professions is captured within the generic level statement of Nurses and Midwives Queensland Health Award. This is a state award from 2015, and the Nurses and Midwives Queensland Health and Department of Education Certified Agreement. We refer to this as the Enterprise Agreement EV11 2022. The generic level statement capability has behaviours, and they are formed under 5 domains of practice, which are predicated on the strong model of advanced practice, direct comprehensive care or provision of direct care, support of systems, education, research and professional leadership. The leadership domain capabilities and behaviours need to be considered and realistically related to other generic level statement domains, as the integral nature of leadership translates through every classification of nursing and midwifery in our state. As such, effective nursing and midwifery leadership is critical for strengthening integration of safe, high-quality care and creates positive work environments that promotes positive person-centred or woman-centred outcomes and experiences for consumers and services and staff alike. Queensland Health has also committed to system reform to ensure equitable health outcomes for First Nations people, our Aboriginal and Torres Strait Islanders. For this to be successful, the First Nations people must be empowered to lead the design and delivery of care to their communities, as well as initiatives that improve culturally safety within the professions. In 2021, legislative amendments were made to Queensland Health Hospital and Health Boards Act that requires hospital and health services to have their own health equity strategies and ensure that First Nations health workforce across all streams and levels to be at least commensurate with the local First Nations population. Although there is a long way to go, we realise that First Nations workforce and leadership is commensurate with population and community health need. Some progress has been made, both at a departmental level and at a hospital and health service level. In 2022, the Office of the Chief Nurse Officer, my office, employed its first First Nations Nursing Director, and in 2024, after the establishment of the Office of the Chief Midwife Officer, the establishment of a First Nations Midwifery Director, and was made and appointed to. These key leadership positions lead the strategic direction for our First Nations nurses and midwives, but also provide direction and advice related to other programs and initiatives such as those related to workforce, models of care, professional development and education. The Queensland Cancer Clinical Network was first established in March in 2013, and it serves to provide expertise, direction and advice to the Department of Health, Hospital and Health Services, and also, most importantly, clinicians on matters relating to the delivery of quality cancer services across the continuum of care in Queensland. Queensland Health has had a clinical cancer leadership advisory group in some form since 2006, with the Queensland Cancer Clinical Network now covering all Queensland, including hospital and health services. This network comprises of a strong multidisciplinary team of doctors, nurses, allied health and consumer representatives. There are 3 focus areas that have been identified as key bodies of work over the next 2 years that we are really focusing on. These are about improving standards, access and equity of cancer care, real-time capture, sharing and interpretation of data and informatics in cancer care, strategic positioning of Cancer Network as a state stakeholder and a key to advise health planning, new technologies, workforce planning and linkages across our state, and in particular, informing some of our Australia components. We also have a network of nurse navigators and care coordinators. These are an essential part of cancer care service delivery in Queensland. With the state's population being so distributed and diverse, receiving best treatment means travelling great distances and coordinating a large number of appointments with specialist teams over an extended period of time. Presented here is the core pillar graphic, which demonstrates the wraparound nursing skills set of navigation service. Many cancer services in the state have applied this logic to cancer care coordination, with the mission to have experienced cancer nurses dedicated to supporting and guiding patients through diagnosis, treatment and follow-up care. They act as a single point of contact, access, and the individual, the patient and family for needs as they change over time throughout their cancer journey. By supporting the person and the family with referral to the most appropriate person to meet the needs, improving health literacy through education and information on diagnosis and treatment options, coordinating tests, treatments and appointments, providing a link for all of the services to get to the patient to reduce contact fatigue and confusion is paramount to the success of navigation. This has been an enormously successful program in Queensland and is another means by which nurses work to their optimal scope. Nurses continue to demonstrate leadership in clinical practice, ensuring not only for the growth of the profession, but finding ways to ensure that patients have access to high levels of cancer services. Here are just some examples of nurse-led cancer services emerging in Queensland. On the 1st of July 2024, the National Bowel screening program reduced the eligibility age for the program from 50 years to 45 years, as it recognised that early detection and intervention can reduce the development into deadly bowel cancers. In 2016, the Office of the then Chief Nursing and Midwifery Officer worked with the Queensland University of Technology to develop a graduate certificate in gastroenterology to support advanced education in gastroenterology for registered nurses, and is linked to the education pathway for the Master of Nurse Practitioner program. Data indicates there are significant wait lists across most health services for Category 4 to 6 endoscopy procedures in our state, and that inadequate workforce in endoscopy services across Queensland and nationally is known to be one of the causes for extended wait lists. We have 7 nurse practitioner nurse endoscopists from this program, and they've contributed to improving access for services for patients requiring follow-up screening, review and diagnostic services. They perform dedicated nurse endoscopy lists in addition to current medical endoscopy lists, working to optimal scope of practice, including managing here in Queensland and their own sedation for the procedures. This is particularly effective in regional Queensland. Here is a media snip highlighting the significance of the success of the program and the increasing scope of nurses in cancer screening and prevention. As a result of the new changes of the screening age and the growing wait lists, the Queensland Government have reinvested in this program, and 3 more nurse practitioner, nurse endoscopists have been employed and commenced their training this year. There are other specialist cancer nurses and services evolving, such as the Gold Coast University Hospital Prostate Cancer Specialist Nurse and a home for chemotherapy service. As Queensland is such a diversely populated state, the emergence of telehealth services has been a significant lift in access to care for Queenslanders. This was especially true during COVID for cancer patients, as remaining in isolation from other people was important, as their vulnerabilities were greater than the general population and treatment continued in many and special ways. The capabilities of cancer nurses to quickly adopt telehealth strategies were demonstrated to keep in touch with patients, to support them to continue treatment and be safe, and to be a safeguard to field all of the questions during a scary and difficult time in our country. Barb Kelly is one such nurse who leads a couple of projects in far north Queensland to improve access to cancer services through the development of the Cancer Oncology unit in the private hospital that is there, but also in establishing the Far North Queensland Tele-Oncology project, which provides telehealth cancer nurse support for people living well away from the main treatment hub in Cairns, to provide support and advice, education and nursing expertise, monitoring for physical deterioration, symptoms, side effects, and psychological impacts of cancer diagnosis and treatment. It is an exemplary virtual care nurse-led model. Also led from the Far North Queensland in Townsville, the partnership with the Australian Government, Queensland Hospitals and the nursing team involved in coordinating cancer trials to establish a national capability of recruiting patients from all over Australia. No matter where they live, they were incorporated into cancer treatment trials by the use of tele-facilities. Rather than being excluded from the trial participation simply because of location, this enables every Australian the opportunity to participate in a clinical treatment trial if they wish, with expert cancer care trials, providing patient recruitment, consent and education, and supporting local nurses in the administration of drug trials and monitoring of the patient. We also provide empowerment to our nurses We do this by offering forums where nurses can congregate and grow together, just like you are doing here today. Passionate about practice symposiums and provide opportunity for participation in reference and advisory groups. The other component is to provide a platform for engagement of nurse unit manager, leadership forums, enrolled nurse forums, grand rounds, showcases, and passionate about practice symposiums held each year between our state and the hospitals and health services. We have a focus on leadership, but you need the platform. As I mentioned, you're doing this today. Cancer care is also about being and I guess being viewed as specific context of nursing care, growing a pipeline of future leaders, start with graduate recruitment and retention. First Nations graduate pathways, nursing as a career choice for school leavers, and the pathways need to be functional and easy to access. Electronic education platform for nursing and midwifery, assessor preparation and recognition of prior learning and support for trauma-informed care, such as mental health clinical supervision workshops, is absolutely adding to the quality of services that nurses provide. Nurses cannot lead in isolation. However, if there is not a level of support and functional systems that support shared decision-making at all levels of the system of healthcare, all levels of the multidisciplinary healthcare team, there will not be advances and you will not see what you are aiming to achieve out of this conference. It all starts with the organisation being focused on and ensure there is an investment in nursing leadership. The process of an individual understanding how they can shape systems, drive innovation to achieve outcomes is about leading oneself and engaging with others. There are the basis of magnet leadership philosophy. And these are some examples of the nurse leader understanding oneself and then ensuring they work with their leader to advance to the best that they can be. Planning as the foundation to meet the needs of our community is important. In Queensland, we set up the Nurses and Midwives Enterprise Bargaining Innovation Fund. The provision of non-recurrent funding for 19 projects that improved, developed or implemented innovative models of care was really focused on quality and safety. This included 2 projects in Darling Downs Hospital and Health Service, the Child Development Clinical Nurse Consultant, Nurse Navigator Refugee Health. The projects have been completed with many positive outcomes being recorded. However, continuous improvement is important to direct further growth and development from both an individual and organisational perspective. Key to all good leaders is the balance that we carry on critical components of self-awareness, self-management and self-reflection. Well-being of oneself and the staff that we manage is critically important. We work in an emotive profession. We have strong relationships with our patients that provide advocacy and clinical care. We have strong relationships with our multidisciplinary team, again, providing advocacy and safe care. But you need to look after you and ensure that well-being is the focus of your leadership journey. Nurses across the globe have had many challenging years. Nurse leadership has been paramount to ensure healthy communities, healthy systems, healthy families, and a healthy economy. Nursing has been at the heart of it, and many different components come into play to support the growth and development of future leaders. As you can see from this slide, the dynamic is codependent on so many different aspects. Groundbreaking research in cancer care continues to astonish what leaders in healthcare have achieved to make treatments better and ultimately cure and extend people's lives that are impacted by cancer. The Institute for Healthcare Improvement provide a simple triple aim of improving care coordination, patient health literacy, and focusing on reducing the burden of disease. The triple aim is a great place to start for nurse leaders to make system-wide impact for improvements, but to be able to evaluate and demonstrate the impact of these improvements. I want to draw you back to the Sustainable Development Goals. Not one of these 17 goals do not have some type of connection to healthcare. In a work where cancer care can take over many aspects of our lives, our families and our community, we all strive to ensure our world health is foundational to healthy self, healthy family and healthy community. I thank you for your time today. I appreciate and honour to present to you fostering nursing leadership at all levels. It truly is a foundational principle. Thank you for your time. Most appreciated.
Thank you, Dr. Kelly. How we can empower knowledge, specialization, shared decision making. Shared decision making is the word we echo now everywhere. And also how they can take care of the patient and themselves. And the important feature and very important feature of the talk was empower yourself, your family, community, generation. Thank you very much. So now let me introduce our next respectable speaker, Dr. Professor Sui, Associate Professor of Nursing and Rehabilitation, Chengdu University, China. Professor Sui is a PhD nurse. She did her PhD from the University of Pennsylvania, USA. She's serving as Associate Professor at Chengdu University, China. She's a renowned researcher and an expert in quantitative methodology and advanced statistic analysis. She has several publications in high-profile journals. So please, a big round of applause for Dr. Sui.
Dr. Jenny, Ms. Gopina, and dear colleagues and guests, good morning. I'm Chen Nanxue from the School of Nursing, Chengdu University. My presentation today is research impact in nursing, so I'm going to shift the perspective from clinical practice to research. This is the outline of my presentation, and firstly, I would like to introduce my university. I'm sure we are familiar with this map. We are very close friends between Pakistan and China, and this is the distance between Lahore and Shandong province. The Shandong University is located in Shandong province. If we take a closer look, this is where Shandong is. It's in between Beijing and Shanghai. So Shandong University is one of the oldest universities in China for modern higher education. It was established in 1901. It's one of the national comprehensive university under the direct administration of the Ministry of Education. It ranks number 15 in China. We wish we rank number 5, but we ranked number 15 in China and 360 in QS ranking this year. Shandong University is also one of the largest universities in China in terms of number of students and size. We have over 65,000 students in total and 1,600 international students. We have 8 campuses in Shandong province, 6 campuses in Jinan City, which is the capital city of Shandong, 1 campus in Weihai City, and another campus in Qingdao City. So here I list these are the 6 campuses in Jinan City, and Baotuquan campus is where I'm working and Miss Lubna is studying. So this campus, all schools related to medical and health sciences located on this campus. so it's also called Chilu College of Medicine. There are 8 schools under the administration of Chilu College of Medicine. So Chilu College of Medicine was originated from the Chilu University that was established in 1864. And School of Nursing and Rehabilitation is one of these 6 schools. So our school's mission is to nurture next generations of nurses to meet the needs of Healthy China 2030 initiative. Our nursing subject ranks the top 5 in China. We offer bachelor, master, and doctoral programs. We also have a postdoctoral working station, which means postdoc can work with our professions to do research. Our faculty members have a very variety of research focuses, including healthcare for older adults, stress and health, management of chronic conditions, women and children's health, evidence-based nursing and knowledge translation, and intelligent rehabilitation. So if you have any interest of pursuing a higher degree in nursing or facilitating some research collaboration, you are very welcome to reach out to me. Speaking of research, this is my topic. There is a shift in missions of university from knowledge generation from research towards their role in contributing to society through the usefulness of research. And the research impact has become the evaluation criteria for many researching funding agencies. That's why I'm choosing this topic to talk about research impact. But before jumping into research impact, let's refresh our memory about research. So research is a systematic and scientific inquiry of a topic relevant to a context. The process of research involves thoroughly search and critically review evidence, developing a research question, developing a theoretical framework, designing appropriate methods, data collection, data analysis, and interpretation of results and dissemination of findings. The goal of research is to create new knowledge or update our current knowledge. A program of research is a research interest or an area of research in which there are very specific objectives of knowledge generation and advancement accumulating from evidence. It should be very relevant to healthcare practice, standards, and policy. And of course, it captures the passion and commitment of us as the researchers. So there are certain steps to building a program of research. First, importantly, know your passion and interest. And then we need to ensure the significance and importance of our research topic in healthcare. We need to know the literature and practice in the area. We can use some outcome models to help us think the whole program. We need to nurture interdisciplinary partnership and collaboration, and to publish and publicize our study findings. And equally importantly, we want to have fun along the journey. We usually use FINDER to evaluate if a research program or question is good or not. FINDER stands for feasible, interesting, novel, ethical, and relevant. For relevant research, it means this research relevant to main healthcare or nursing issues, patient outcomes, cost, and other top issues. And this actually means we want our research to be impactful. So what is research impact? The definition of research impact is evolving, and there are many definitions out there, as I listed in the left side of the slide. But the most common definition is by the Research Excellence Framework in UK. They define research impact as an effect of change or benefit to the economy, society, culture, public policy, public services, health, environment, and quality of life beyond academia. Why does research matter? So there are many reasons for this. Political reason, environmental reason, social reason, technological reason. For example, politically, there are increasing pressures in politics for value for money, which means there's demand for transparency and accountability of how public research funding are used. So they want public research funds lead to impactful outcomes. So all these reasons together make research very, very competitive. So as researchers, we need resources to support our work. So we need to demonstrate that our work produce some differences or changes that are deliverable. Thinking about research impact can help us increase the chance of getting funded and progress in the research career. And there are many other drivers. You can see here there is a model of drivers for research impact from the advanced higher education leadership governance and management in the UK. In addition to system, sector and institutional factors, there are also individual factors that drive we think about research impact. For example, impactful research can bring researchers reward, recognition, and assurance. For example, promotion, incentive, and reputation in the community. And focusing on research impact has many benefits for researchers, research users, research management stakeholders, etc. I will not talk about the details, it's a lot. If you are interested, you are welcome to search for this toolkit. It's available for free online. So how do we evaluate impact? We evaluate impact based on research outcomes and effects, both quantitatively and qualitatively. We also need to take time into consideration because it really takes time for research to produce impact. There are many categorizations of impact. So here I present 4 types of research impact. The first type is use of evidence, which means whether our research findings or research evidence is used in law, government policy, strategy, regulations, standards, guidelines, and priorities. The second type is research product, which means whether our research produces deliverable products such as training programs, courses, interventions, research methods, etc. The third type is effect on individuals, which means whether our research increases awareness and understanding or change attitude and behavior of individuals. The fourth type is effect on groups or organizations, such as organizational development, organizational or network behavioral change, or improvement in organizational performance or end user satisfaction. So how do we make impact happen? These are the journey of a research impact from initial input to the final contribution, directed by motto and intrinsic call. In the initial input stage, we researchers need to think about our research interests, our expertise, what we have done, and find out the most important research problems we need to focus on. In the activity stage, researchers present the research evidence to research users through activities such as symposium like this, briefings, lectures, workshops, etc. And then research users are engaged and involved in some way. And through engagement, we want research users to recognize the usefulness of research evidence for their practice. And then they may change their knowledge, skills and abilities that is capacity for use. And this will lead to changes in behavior or practices. And then we create changes of the problem we focus on at a local or national level. Okay, that's about like definition, basic knowledge about research impact. And next, I would like to take a couple of minutes to introduce my own research journey. This is very simple timeline, shows my research journey. My research journey started in 2010 when I started my master's degree. I did a research project on adverse childhood experiences and its effect on adolescent executive function. So my PhD at University of Pennsylvania is a continuation of my master project. My PhD dissertation is on child maltreatment, behavior problems, and neurocognition, mean and mediation effects. So I joined Shandong University in 2017 after my PhD. The first grant I got is to investigate the needs of public parenting service and the effectiveness of the universal parenting intervention for underserved families. And through this project, I recognize a challenge for parenting, a new challenge for parenting, that's digital device use among very young children. So I developed another project on digital parenting and screen use among children, including healthy children and children with health conditions such as epilepsy and cancer. I got funding from the National Natural Sciences Foundation of China, and because of this, this foundation focuses on to understand the fundamental mechanism of a phenomenon. So I also investigate the epigenetic and circadian mechanisms linking parenting screen use to child mental, behavioral, and cognitive outcomes. So to sum up, my program of research focuses on the relationship between parenting and child mental health. These are the steps this is my thinking of my steps for my whole research career. From theory and groundwork to modeling to exploratory trials to definitive RCTs and to long-term implementation. You may notice the different colors of each box, which means the red colors are I have done a little thing. I'm still doing something for this step. The gray color indicates that I haven't done anything yet, but I'm going to do in my future. I think I have achieved some impact in academia. I have published 74 peer-reviewed publications in well-recognized journals. I delivered 19 conference presentations. I have 2 active grants now and completed 6. I'm co-leading 5 grants at provincial and national levels. I have an H index of 20. Most cited papers have a citation of 123. I edited a special issue for Frontiers in Psychology, and I have submitted a research summary to the National Office for Philosophy and Social Sciences in China. But I haven't done a good job in research impact. I need to do some self-reflection, but I would also want to share this honestly with you. Those other impacts are targeted. I would like to increase awareness of the importance of parenting and child mental health. I would like to influence the risk models, healthcare services, education policy, and industry with my research. I think I have done a little bit on increased awareness because my research was covered by some Chinese media to increase their awareness among parents and practitioners. I have developed an integrative model of parenting intervention tailored to families with different levels of risk. It's specifically delivered by primary healthcare providers. But I still need to, I have done some pilot trials on this, but I still need to do some RTTs and long-term implementation on this. And I expect that my research will influence healthcare services, education policy in the industry in the future. And to achieve my goals, my future research will focus on enhancing understanding of the physiological, genetic, and epigenetic mechanisms of the phenomenon, with developing and testing parenting interventions to inform best practice and integrating effective interventions to regular health practice based on implementation science, which I will talk about tomorrow. Okay, that's all about my presentation. So there are four take-home messages. First is the purpose of research is to build the academic knowledge base. The research impact emphasizes on the changes that research brings about beyond academia. There are many drivers of research impact, and there are many indicators of research impact. And we need to consider research impact because this will be beneficial for our research career. And it's never too late to start thinking about this. I would like to acknowledge my supervisors for my master and doctoral programs, Professor Paul at Shandong University, Professor Zhang Hong Liu and Cynthia Conley at the University of Pennsylvania. I would like also to thank my research team. This picture is not up to date. I should put a picture with Lubna in it, but I don't have it at hand. So. Those are my collaborators in different universities and different fields. I would also thank the funding agencies to support my research. I think we have question session event.
Thank you so much. For highlighting significance of research, significant environmental research in life. Most important, how nurses are and can contribute to the building of knowledge. And this research impact was very much significant from the work which you are doing in the field of nursing. So with this, once again, thank you very much. So now I would like to
Vidya and team sitting on the technology IT. We have received a complaint that online voice is not clear. So please check them.
Now, I would like to invite Mr. Nasir Khan, Associate Director of Nursing, Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore, to give a talk on establishing a benchmark of diversity, equity, and inclusion in oncology nursing workforce. And he would be talking about the challenges and solutions. Mr. Nasir Khan.
Thank you very much, organizing committee. Honorable guests, dear colleagues, nursing leadership, Assalamu alaikum. So I'm giving this responsibility to highlight the importance of diversity, equity, and inclusion, which is very, very important. And we see this group is also a diverse group. We have different people from nursing colleagues, from other part of the country. We have honorable guests from China, as well as we had a speaker from Australia with a visual level. So and wonderful. So these will be the main objectives of my presentation. So we'll highlight the how can we define the diversity, equity, and inclusion. This is now the new aspect of workforce, which is seen as very important aspect in order to improve patient outcome and improve workplace environment as well. So we'll highlight historical perspective, benefits and current trends of PI in nursing, and challenges which we are facing in order to produce a diverse workforce, Pakistan, and solutions, and as well as with so diversity is as defined by American Association of College of Nursing, is that it's not only limited to age, gender, race, ethnicity, and national or immigrant, refugees, physical, functional disability. It's more than that. And if we see the other term, which is equity, so there is a slight misunderstanding between normally that is equality is there, but we need to see the importance of equity. Equality when we are providing the same treatment to all in equal manner, in uniform manner, but is it that appropriate for that individual? It's very important. Uh, if we see equality and equity in this picture, it's also evident that equity is a step further from equality, and we need to see the needs of the diverse people who we have in the workforce, as well as the patients are encountering. So equity as defined by, again, by this American Association of College of Nursing, is the ability to recognize the difference in the resources or knowledge related to allow individuals fully participate in society, including access to higher education and goal of overcoming obstacles and core fairness. This is important. So in the inclusion, we need to ensure that everyone works is having their perspective and have their voice, and that is welcomed, acknowledged, and also the environment is provided in it. So if you see the history of this diversity, equity, and inclusion, so it all starts from America, where in the US there was a book published, Institute of Medicine. They have many books published on the quality and patient safety, but this was something different, which was related to see the workforce impact on the patient outcome. Then later on, there was another book which was published by the Institute of Medicine in the US, which was related to unequal treatment, and there both of the theme which was highlighted in the book recommendation to ensure that availability of language translation, community-based care that have different communities based on the language, ethnicity, and etc. And also to include cross-cultural education, which is also very important. In one of the slides by your honorable speaker from Australia, we have seen that there was a prostate nurse, was a male nurse looking after patients who have might have, or maybe he was working for screening and also providing the care. That was important, that to provide relevant sensitivity to that part of the care. So this is also very important. If we see the in simple words, this diversity is the difference we have in the workforce. Equity will be access, opportunity, and support which is provided to them. And then there is a genuine involvement, which is very important in terms of inclusiveness, if we want to talk about that. So another term which is very much evident in the literature is disability, visibility, and unmasking albinism. It's very important that we need to identify that, first of all, we need to know about the culture, the other we have in the workforce. So disability, in fact, is natural part of human. Albinism is referred to something we see in the our environment, that is something which is highlighted in terms of disability or other differences we have in the workforce. So one of the data which was published in US is that disability unemployment rate was 12.1% as compared to 5.1% among people who were not disabled. And in post-COVID, we have many lessons learned from COVID, but one of the message which was published again in this literature was improved worksite environment structure and policies support nurses who experience various permanent or temporary disabilities, including mental health disabilities, occupational stress, and age-related concerns. So again, accommodating those nurses who are disabled. In Pakistan, unfortunately, I was also discussing with my colleagues and senior leadership that even as of now, we don't know how many disabled nurses we have in the country and what is done for those nurses and how we, this is one part of diversity. So similar, there are other features and characteristics of diversity features. So that is still to be gained in larger view. Uh, Another thing which is important that in the practice side, we need to identify, uh, for example, in this literature, this study was published, and what they have done is that uh, all aspects of purchasing, when they were purchasing equipment, so all aspects were considered. For example, purchasing equipment which will be allowing those nurses who will have vision problem or those who will have height related issues. So those were covered in this perspective. So they were involved. Another important thing is in terms of managing is the language which is used in the workplace. Also important, for example, now the better language, specific language uses differently able instead of calling them disabled. Handicapable is replaced again, handicapped also is used. In that literature, they have many other small interventions which they have done. So cultural competency is very important. Cultural competency, we know that we need to know the identify the culture which other colleagues have. So what are the practices? What are the values they have? We need to identify this, and we should be able to culturally competent, not only among our colleagues but also to the patient. Patient is in the center, so we need to identify that we have enough knowledge, skills, and attitude. Okay. So if you see the numbers from Pakistan, so 24% of the nurses published on Pakistan Nursing Council site, they are male, and 76% of the female. So we are mostly diverse in nursing in terms of this. So beyond that we don't have any such number that further description of the diversity exercise in terms of religion, in terms of language, and etc. If we compare the male-female nurses ratio according to the other countries, so as you see in UK, US, and Australia, the number and even Canada, the number is somehow 9 to 11%. They have males, and in UAE, KSA, India, and Pakistan, it is somehow 24%. So there were two more books which were published based on the initial book, and this was all about the future of nursing. And the conclusion was that the nation population become more diverse, so the sustaining effort should be there to diversify the workforce. This was seen in terms of the patient population. They have few other recommendations which were related to nursing education, that there should be some pipeline programs for those who are underrepresented groups. Similarly, access for the students to avoid barriers. Uh, in nursing research, so there was a stress on the encouraging minority researchers to address healthcare disparities. In clinical practice, they have recommended that there should be a DEI exercises and positive impact on the nursing workforce, and that's why in the Magnet ANC, they have a standard on that. There should be a DEI at least initiated by nurses. So benefits will be definitely patient care, and there will be a trust, addressing healthcare disparities, improve patient outcomes. Cancer is one of the leading cause of death in Pakistan, and cancer, if we divide by gender, so breast cancer is very much evident in the country. So talking about breast cancer and breast screening, it's very sensitive topic. So if we have a diverse group, nurses from that community, so they can better provide those interventions which are related to that. Australia, they have a prostate cancer, some male nurse. So again, it is important that to identify those sensitive areas which we can use diversity in order to enhance patient outcomes. So there was a study which was related to cultivating innovative work behavior of nursing through diversity climates and mediating role of job crafting. So many of the nurses, they have modified their job according to the goals. And in the results, they have proved although it was a cross-section comparative study, but the findings that those were evident that the more diverse the group, the more innovative work behavior they have. So this is how they have measured it in this study. If we see images from Pakistan, so this is one of the school which is running in an area, and I have taken it from their website. So they have a diverse group in order to promote diversity at the school level. If we see this lady again, this is working in one of the petroleum companies. She is differently able, but somehow she is part of actively participating in the productivity of that industry. Cricket or favorite area, again, you see, they are equally participating. So a platform is provided, so they are not feeling that they are disabled. There are centers, disability job centers. So, and again, if you are looking at the polio campaign on TV, so there is a lady coming who is who was having a polio, and now she is participating to eradicate this disease, and she is participating in polio campaign. Nonetheless, nursing. So, although on Pakistan Nursing Council level, I haven't seen any rule or anything which is allowing nurses or those candidates who are disabled and who want to get admission in nursing. However, I have seen this ad. It was very attractive because they have certain percentage specific for disabled nurses. Similarly, it was from Punjab Healthcare Commission. So, what are the challenges in our country? In our country, you know how many languages are spoken in our country? More than 77 languages are spoken. And we have more than 15 cultures existing in our country. These are the cultures who are evident and are reported. Many of them, many other are subcultures communities. The socio-cultural perspective about nursing is still not evident that many of us, we are, for example, in cities, we have the knowledge that male nursing, female nursing, etc. But at community level, there is still a concept that it's a female evident profession. So we need to have a policy and initiative and arrangement and support, and then again to see the status in order to promote diversity, equity, and inclusion. There are some resources available, however, they are not sufficient. Cost of training is very expensive. Oncology specialist program, market competition, policy. So this was the report which was again published in US, and this was related to transforming nursing education responsibility of 2020 and 2030 report, and which have clearly highlighted that we need to create policies that include, promote diversity and racism well-being, as well as to design the curricular resources and activities which promote DEI and creating support for those who have some sort of diversity in the background. So in the solution, this will be the last slide. So we need to have a DEI survey. We need to have a dashboard that how much diverse the nursing force we have, and what is the benchmark to be set for that. It should be in the literature. It was mentioned that it should be based on the patient population. The patient population should be the baseline. I think you can have a diverse workforce. We can have a curriculum development which is maybe like the graduate level, they have something diversity, but slightly touching diversity, but we need to introduce something about that. And we to remove recruitment barriers, support underrepresented group, enhancing collaboration and partnership, and creating awareness. So diversity is the richness of human experience. Inclusion is when everyone feels connected, valued, engaged. We believe that because of diversity, we excel. Through inclusion, we respect and focus on equity. We serve, heal, educate, and awaken. Thank you very much.
Thank you very much, Mr. Khan. It's indeed that it's important to emphasize the diversity, equity, and inclusion, especially in early nursing practice, both clinical and education, where we are dealing with population with different needs in terms of culture and belief, racial, ethnic, gender, and disabilities. And upon acknowledging this DISD, we will be able to enhance patient care and trust, and then will improve patient outcome. So for the next speaker, we would like to welcome Mr. Adnan Yaqub, our very own. He's the Principal in Nursing Education in Shaukat Khanum, and he's going to talk about enhancing nursing empowerment for development of interventions through research. Welcome.
Thank you so much. Assalamualaikum and good morning, everyone. Today I'll be speaking on a topic on enhancing nursing empowerment for the development of intervention fields. So nursing empowerment is a multi-dimensional process that allows nurses to gain greater clinical authority and decision power. It's important because it is more than just autonomy. It's about fostering leadership, self-advocacy, and ability to improve clinical practice on a larger scale. Empowered nurses are capable of driving change, implementing evidence-based practices, and improving care across various healthcare settings. The connection between empowerment and better patient outcomes has been well documented, and it is essential that we equip nurses with the tools to lead. Because nurses interact with patients more than any other healthcare professional in the clinical. So their unique position allows them to identify issues early and propose interventions that can significantly enhance patient care and patient outcomes. So why it is important? Why nursing empowerment is important? Because nurses play an important role in transforming healthcare delivery, especially as their scope of practice continues to expand. We see that more nurse practitioners, nurse care specialists, and advanced nurse practices and breast care nurses taking on leadership roles in patient care in many countries. And now their roles are expanding. So when nurses are empowered, they can make autonomous decisions that are aligned with the latest evidence-based practices, as the studies have shown that empowered nurses contribute to lower patient mortality rates, reduced hospital readmissions, and higher patient satisfaction. It means that the empowerment is not just a theoretical concept, it directly impacts the quality of care we provide as a nurse. So research is a critical element, as many of the respected speakers have talked about it. It allows nurses to base their clinical decision on robust, high-quality evidence, which leads to better patient outcomes. Nurses who participate in research not only improve their clinical skills, but also their ability to drive healthcare innovation. And in today's age, we need innovation in healthcare. So when it comes to developing effective interventions, we need to follow evidence-based frameworks like Medical Research Council, or which we can say MRC guidelines. This approach is systematic and ensures that interventions are well grounded in scientific evidence. The development process begins by identifying a clinical problem, followed by co-creation of activities with other healthcare professionals, and then we evaluate the intervention. So MRC framework outlines a structured approach for developing and evaluating a complex healthcare intervention encompassing 4 key steps. This systematic approach, which involves development, feasibility, and piloting, evaluation, and then implementation of the evidence design. This systematic approach ensures that interventions are relevant because as a nurse, we develop interventions, we we encounter patients with their feedback patients, their opinions, and how they want to be cared. So ultimately, it will lead to improved patient outcomes for the target population. And by engaging with stakeholders like other healthcare professionals working in the hospital, nurses can create impactful solutions in healthcare by using such tools. So if you look up in the literature, there are plenty of examples where nurse-led different interventions, whether it be a field of chronic disease management like diabetes, COPD, heart failure, and palliative care. So let us analyze few of the examples. So in this study, the effectiveness of nurse-led diabetes management effectiveness program on glycemic control was evaluated. Their findings revealed that participants in the nurse-led program had substantially lower HbA1c levels as compared to control group. Similarly, another study evaluated the effect of nurse-led family pulmonary rehabilitation program on the patient's quality of life and exercise capacity. And the findings revealed that the patients who were in the nurse-led group had more good quality of life and their exercise capacity improved as compared to the control. So this is another example of a nurse-led home-based cardiac rehabilitation, which is my PhD project. And it was a mixed method exploratory sequential design in which initially we developed home-based cardiac rehabilitation through qualitative interviews from patients and various healthcare professionals, which included cardiologists, cardiac nurses, nutritionists, psychologists, and pharmacists as well. So after the intervention development and validation, it was implemented to see how it influenced patient outcomes as compared to routine care. So just to show how it affects the patient outcome, I have added 2 slides from the data comparing projects. So one of the outcome variable in my study was quality of life of patients. So in this slide, you'll see that quality of life scores in the both groups, in the intervention and control group. So home-based cardiac rehabilitation group showed a 58% improvement in the quality of life from the baseline after 90 days. And it is increasing to 66% at 180 days. So since we have taken data at 3rd month and 6th month, so a nurse-led intervention had led to the better quality of life in patients in the intervention group. On the other hand, there is an improvement, but the improvement in the home-based cardiac rehabilitation is far away from the far better than the control group. So in the control group, we saw around 21% improvement at 90 days, rising to 33% at 180 days. So results emphasize that the greater effectiveness of home-based cardiac rehabilitation in enhancing patients' quality of life compared to routine care. Additionally, if we compare the difference of improvement in quality of life in the both groups, so in the intervention group, they had 37% increase in quality of life as compared to the control group at 90 days. And by 180 days, their quality of life in the HBCR group increased to 33% as compared to quality of life in the control group. So as part of another variable, as we see that many of cardiac patients after heart attack in our society, they left their job, and their family doesn't allow them to work, and they want them to stay on the bed, and they provide everything on the bed. So it was another objective of our study that this intervention should allow patients to retain their jobs even after their heart attack. So we compared that data as well. So at the time of admission, at the baseline in the intervention group, there were 38 patients who were employed, and after the 90 days, 81% of the patients retained their job in the intervention group, which increased again to 10.5% from the 90 days. And we can say that as compared to baseline, the patients who were in the intervention group retained 110% their jobs. So not only they retain, but also their rate of employment increases after the 180. But as compared to the control group, if you see, the patients during the admission, there were 44 who were employed, and their retention of employment came down to 56% only, and their retention was 43% as compared to the intervention group. And then it increased a slight with 23 patients who were employed, but from the baseline, again, their retention was 52%, half they retained the job. So if we compare the both groups, um, in patients in the home-based cardiac rehabilitation group, improved their job retention almost 50% than the control. So this is how the nurse-led intervention improves their quality of life and their in their daily living. So what are the barriers to nurse-led intervention development? Because we use the intervention, we apply the intervention, but we don't develop the intervention. So a contextual intervention will be helping for our patients to improve their clinical outcomes. So in developing countries, there are significant barriers to nurse-led research and intervention development, which includes limited research funding, hierarchical healthcare structures, and restricted access to advanced training, and all contributes to this challenge. In many countries, nurses are seen as primarily as caregivers only, not as researchers or not as leaders. So this limits their ability to drive innovation. Moreover, the lack of institutional collaboration can significantly hinder nursing empowerment for research, and without a collaborative framework, uh, opportunities for nurses to engage across institutions and disciplines are limited, which restricts their sharing of knowledge and resources. So this absence can lead to reduced access to funding and training programs and essential research tools necessary for conducting the health. So what are the pathways how we can overcome these barriers? First, we need to focus on enhancing nursing research capacity through advanced education such as workshops, master's and PhD programs, uh, which provide nurses with the necessary research skills. Interdisciplinary collaboration is also key. By working with other healthcare professionals, nurses can develop more robust and effective interventions. So additionally, global networks like the Global Health Network and these offer available resources and mentorship for research opportunities. And by tapping into these resources, nurses can expand their knowledge, build international partnerships, and contribute to global health initiatives. So this is an example of empowering nurses through workshops, such as one conducted in the collaboration with uh, uh, Global Health Network in September by the HKM. There were two workshops which equipped participants with the knowledge on significant research in nursing, as well as practical skills for developing research proposals. And these workshops cultivated a collaborative culture among nursing professionals. So we also know that if we really want to empower nurses, we also need a policy and organizational support, and without which we cannot do anything. So advocacy for policy reform is essential to ensure that nurses have the authority to lead research and influence clinical guidelines. For example, a policy that allows nurses to lead clinical trials or design care protocols are vital in promoting nursing research. So by investing in education, building research infrastructure, and educating professions, supporting policies, we can ensure that nurses are equipped to develop and implement evidence-based interventions. So this empowerment is not just beneficial for nurses, but it is beneficial for patients and healthcare system as a whole. So this is a call to action which can be done by supporting research, mentorship, and international collaboration in our respective institutes. Together, we can create a healthcare environment where nurses are fully empowered to lead and innovate. These are the sources. Thank you, sir.
Adnan, and I'm so proud to see now. There were times when we were talking about the processes of research in nursing in Pakistan, and now we have started talking about our researches in Pakistan. That's a proud moment. Um, and inshallah, there are more to come tomorrow. You will enjoy young researchers presenting uh, their papers. Um, uh, I am sorry to announce that we have short of time because we have finished the time of our session. You might have questions to the presenters, so we can do those. Presenter will be available in the lobby or in the tea area to have your question answered, or maybe you can write to them. Um, I would again say thank you so very much for everyone joining us in this session and making it a pleasant, learned, and unified experience. I can see a lot of people coming from other institutions. Initially, they were not with us, so I welcome and I thank you all. And I can see the hall full of nurses. So the collectiveness of nurses, let us clap for us. And I'm sure that more than 50% of these are those now today who are degree holders, and inshallah those who are going to have the degree soon. So thank you so very much and congratulations for your success. Thank you.